The heartbeat depends on a finely tuned electrical system, where every impulse starts, travels, and ends with precision. But when this rhythm is disrupted, the consequences can be life-threatening. That's where antiarrhythmic drugs come in. In this video, I explain the mechanisms of action of the Class 1 antiarrhythmic drugs, especially how they target sodium channels to control cardiac rhythm. To fully understand how these drugs work, it's important to first grasp two key concepts: the ionic basis of cardiac action potentials and the different ways in which drugs can interact with and block ion channels to alter cell behaviour. If you're not already familiar with these topics, I recommend checking out my two short videos with these thumbnails. They give step-by-step explanations of these concepts and will make the rest of this presentation easier to follow. Links are provided in the description below this video. Feel free to pause here and come back once you're ready, or continue if you're already comfortable with those concepts. Antiarrhythmic drugs are commonly grouped using a modified form of the von Williams classification system developed in the early 1970s. The drugs are divided into four main classes based on their primary mechanism of action. Class 1 drugs block sodium channels. Class 2 are beta blockers. Class 3 mostly block potassium channels, and Class 4 are calcium channel blockers. But Class 1 drugs are a bit more nuanced. They are further divided into three subclasses: 1A, 1B and 1C. All of them block sodium channels, but they do so in different ways and with very different effects on the arrhythmic heart. So the natural question is why? Why do three drugs with the same basic target behave so differently? That's what we will explore. Sodium channels play a critical role in generating action potentials in non-nodal cardiac cells, specifically the contractile muscle cells and the fast-conducting fibres. In contrast, the sinoatrial and atrioventricular nodes rely on calcium channels for depolarization. The action potentials in these non-nodal cells have a characteristic shape. They begin with rapid and large depolarization called the upstroke. After reaching a peak, the membrane potential declines to a plateau which lasts around 200 milliseconds before the cell repolarizes back to its baseline. Between action potentials, the cell maintains a stable resting membrane potential of around -90 millivolts. The upstroke is driven by the opening of fast sodium channels, allowing a rapid influx of sodium ions. By the peak of the action potential, sodium channels begin to inactivate and sodium influx quickly diminishes. The remaining phases of the action potential are then shaped primarily by calcium and potassium channel currents. So, sodium channels are mainly active during the upstroke. As a result, sodium channel blockers are expected to inhibit the upstroke, leading to a slower rising action potential with a reduced peak amplitude. The degree of inhibition increases with higher drug concentrations. This slower depolarization causes a reduction in conduction velocity, meaning the electrical impulse travels more slowly between cells. Importantly, when the action potential peak is smaller, its duration also tends to shorten. That's because a smaller depolarization activates fewer voltage-gated calcium channels, reducing the plateau phase. This is the expected effect of sodium channel blockers on cardiac action potentials. Now let's look at what the Class 1 antiarrhythmic drugs specifically do to the action potential. This slide compares the effects of class 1A, 1B and 1C antiarrhythmic drugs on a non-nodal cardiac action potential. The black trace represents the control, while the coloured traces show how each drug subclass typically modifies the action potential. Note that they all slow the upstroke to some degree, but they have varying effects on the action potential duration. Keep in mind, though, that the actual effects can vary depending on several factors, such as drug concentration, heart rate, and the condition of the cardiac tissue. These traces are representative of characteristic responses, but they are not absolute. We'll step through each of these effects in turn by overlaying each drug trace on the control, so you can clearly see how they differ in their actions. Let's begin by looking at the effect of a class 1A drug. Class 1A antiarrhythmic drugs slow the rate of depolarization, producing a broader upstroke. This reduction in the rate of rise decreases conduction velocity through the myocardium. So far, so good, as expected for sodium channel blockade. However, class 1A drugs also prolong the action potential by extending the plateau phase, which is not predicted by sodium channel blockade alone. The reason lies in their lack of selectivity. In addition to blocking sodium channels, class 1A drugs also inhibit potassium channels involved in repolarization, particularly the delayed rectifier currents. This dual action slows repolarization and extends the overall duration of the action potential. The result is a prolonged refractory period, which can help suppress re-entrant arrhythmias by making it more difficult for premature impulses to propagate. Class 1C antiarrhythmic drugs are highly potent sodium channel blockers, and their effects on the cardiac action potential closely align with what we would predict for selective sodium channel inhibition. In the trace shown here, the action potential recorded in the presence of a class 1C drug exhibits a significantly slower and broader upstroke compared to control, reflecting a marked reduction in the rate of depolarization. This corresponds to a substantial decrease in conduction velocity, one of the defining actions of class 1C drugs. Unlike class 1A agents, class 1C drugs have minimal to no effect on potassium currents. As a result, at therapeutic doses, repolarization is largely unchanged, and the action potential duration and refractory period remain close to normal. This makes class 1C drugs effective for suppressing fast arrhythmias through strong slowing of conduction. However, it also means that they can be pro-arrhythmic in diseased hearts, where excessive conduction delay may promote re-entry. It's worth noting that at higher concentrations, class 1C drugs can shorten the action potential duration, consistent with the expected effects of sodium channel blockade. I've left the class 1B drugs until last because their effects are a bit less intuitive than the other subclasses. Like other class 1 drugs, they block sodium channels, but they have only a small effect on the upstroke of the action potential, meaning they cause minimal slowing of conduction. Yet, they significantly shorten the action potential. Why? The key lies in the behaviour of cardiac sodium channels. As mentioned earlier, most sodium channels rapidly inactivate following the peak of the action potential. However, a small number remain slightly active and allow a persistent inward flow of sodium during the plateau phase. This is known as the late sodium current. Here's an analogy. Imagine it's the middle of winter and you're cosy in front of a fire, All the windows are shut except one that's jammed open just a crack. That tiny trickle of icy air still affects the room's temperature. In the same way, the late sodium current continues to depolarize the cells slightly, helping to maintain the plateau of the action potential. Class 1b drugs are particularly effective at blocking this late sodium current. By reducing this lingering inward sodium flow, they promote faster repolarization, leading to a shorter action potential and a reduced refractory period. This effect is especially beneficial in ischemic or depolarized tissue, where the late sodium current tends to be more pronounced. You may be wondering, how can class 1b drugs block sodium channels late in the action potential but have minimal effect during the upstroke? The answer lies in the concept of state-dependent block of sodium channels. Sodium channels exist in three key states: closed or resting, open or active and conducting sodium ions, and inactivated or non-conducting even though the channel is structurally open. Membrane depolarization triggers the transition from closed to open, followed almost immediately by inactivation. For most ion channels, inactivation is essentially a one-way path. Recovery requires the membrane to return to its resting potential. In contrast, cardiac sodium channels can briefly recover from inactivation to the open state, even while the membrane remains depolarized. Because the rate of inactivation is much faster than the rate of recovery, only a small fraction of channels reopen. But this brief re-availability gives rise to the late sodium current, contributing a small but persistent sodium influx during the plateau phase of the action potential. Drug binding differs depending on channel conformation. Class 1b drugs have high affinity for inactivated channels and low affinity for channels in the open or closed states. This means they selectively bind during the inactivated state and prevent channels from reopening during the plateau. As a result, the late sodium current is suppressed, while the upstroke is only minimally affected. So what about class 1A and 1C drugs? Like class 1B, they also exhibit state-dependent binding to sodium channels with high affinity for the inactivated state. But unlike class 1B, their binding is not limited to that state. Class 1C drugs, for example, also have moderate affinity for the closed or resting state, meaning that a significant number of channels can be blocked before they even open, reducing the pool of channels available as the action potential begins. However, they show even higher affinity for the open state, so much of their action occurs as the channels activate during the upstroke. Class 1A drugs also bind effectively to the open state, but not the closed state. So these drugs are most effective as sodium channels open during the upstroke of the action potential. Once bound to the open state, class 1A and C drugs may remain associated as the channels transition to the inactivated state. So, while all three subclasses prefer to bind to sodium channels in the inactivated state, the differences in their affinities for the open and closed states help explain their distinct effects on action potential shape and on conduction velocity. This animation illustrates how class 1A and 1C antiarrhythmic drugs selectively bind to and block open sodium channels. We start with the channel in its closed state. In this conformation, sodium ions cannot pass through, and the drug binding site is hidden. When the membrane depolarizes, the channel opens. Sodium ions now flow rapidly from the extracellular space into the cell, following their electrochemical gradient. This drives the upstroke of the action potential. Importantly, channel opening also exposes a binding site near the cytoplasmic end of the pore. This site becomes accessible only when the channel is open. At this point, a class 1A or 1C drug molecule which has entered the cell can bind to the open channel from the inside. Once bound, it blocks the flow of sodium ions, reducing both the rate and amplitude of depolarization. Because the binding site is located on the intracellular side, the drug must first cross the cell membrane before it can reach and block the open channel. The binding kinetics of a drug refer to the rates at which it binds to and unbinds from its site of action, in this case the sodium channel. This property differs among the class 1 subtypes. Class 1B drugs exhibit relatively fast binding kinetics. They associate with the channel quickly, but also dissociate rapidly, often within a single heartbeat. As a result, they produce only transient blockade and have minimal effect at normal heart rates. The class 1A drugs have intermediate kinetics. They bind more slowly and remain attached for longer, producing more sustained sodium channel block during each action potential. Class 1C drugs have the slowest binding and unbinding kinetics. They may remain bound for multiple heartbeats, leading to cumulative block with repeated channel activation. These differences in binding kinetics are important because they influence how each drug interacts with the heart's electrical activity over time. This lays the foundation for understanding use dependence, a key concept we'll explore next. Use dependence, also known as frequency dependence or rate dependence, is a key feature of how class 1 antiarrhythmic drugs interact with sodium channels. It refers to the phenomenon where sodium channel blockade becomes more pronounced at faster heart rates or with repeated activation. That is, with increased use of the channel. In this example, a series of ventricular action potentials fires at a normal heart rate of 1 Hz or 1 beat per second. The green stripe indicates the brief period when sodium channels are open during each action potential. The orange stripe represents the inactivated state, and the grey stripe marks the closed state occurring between beats. You can see that at 1 Hz there is only a short window when sodium channels are open or inactivated, states where class 1 drugs can effectively bind. For most of the cycle, the channels are in the closed state where binding is minimal or absent. As a result, a drug molecule may bind briefly during the action potential, but will likely unbind during the long diastolic interval, leading to minimal cumulative effect. Now look at action potentials occurring at 2 Hz or 2 beats per second. Here, the time spent in the closed state is reduced, while the channels spend more time in the open and inactivated states. This increases the opportunity for drug molecules to bind, while the shortened diastolic interval gives them less time to unbind. the outcome is cumulative sodium channel block and greater suppression of the sodium current and action potential upstroke. This is the essence of use dependence. The faster the heart rate, the more effectively sodium channels are blocked. This feature makes class 1 drugs particularly useful during tachyarrhythmias. The extent of use dependence depends on the drug's binding kinetics. Class 1C drugs, which bind and unbind slowly, show strong use dependence. Class 1A drugs have intermediate kinetics and use dependence. Class 1B drugs, which bind and unbind quickly, show weak use dependence. Class 1 antiarrhythmic drugs are particularly effective in ischemic heart tissue. In ischemia, reduced oxygen and ATP availability lead to partial depolarization of the resting membrane potential. Action potentials can still occur, but between beats the membrane remains more depolarized than normal. This persistent depolarization increases the proportion of sodium channels in the inactivated state, even outside of the action potential. Referring to the colour-coded strips from the last slide, you can now imagine that in addition to channels inactivating during the action potential, there is an expanded stripe representing inactivated channels that extends throughout diastole. This matters because class 1 drugs preferentially bind to inactivated channels. Although the fast binding kinetics of class 1B drugs especially limit their effects during the brief open or inactivated states of a normal action potential, the sustained inactivation in ischemia provides an additional window for drug interaction, independent of firing frequency. The result is greater sodium current blockade in ischemic regions, which helps suppress abnormal impulses and reduce the risk of reentrant or ectopic arrhythmias originating from damaged tissue. This summary table brings everything together for comparison of the 3 subclasses of class 1 antiarrhythmic drugs. All 3 block sodium channels, but only class 1A drugs also significantly block potassium channels. They differ in their preferred binding states. Class 1B drugs favour the inactivated state. 1C drugs bind to both open and closed states, while 1A drugs mainly target the open state. The binding kinetics also vary. Class 1B drugs bind and unbind rapidly. Class 1A drugs have intermediate kinetics, and Class 1C drugs bind and unbind slowly. These properties translate into their effects on the cardiac action potential. Class 1C drugs cause the most marked slowing of depolarization and conduction. Class 1B drugs have minimal effect on the upstroke, but uniquely shorten the action potential by blocking the late sodium current. Class 1A drugs slow conduction and prolong repolarization due to their dual sodium and potassium channel block. Finally, their differential channel binding properties influence use dependence and their effectiveness in ischemic tissue. Class 1C drugs exhibit strong use dependence due to slow unbinding, making them potent during high heart rates. However, that potency also carries a risk of causing an arrhythmia. Class 1A drugs show intermediate use dependence, while Class 1B drugs have weak use dependence due to the rapid unbinding. However, Class 1B drugs become especially effective in ischemia, where the persistent depolarization increases the pool of inactivated sodium channels that they prefer to block. Let's end with the main class 1 antiarrhythmic drugs and how they are currently used in clinical practice. Class 1A drugs are quinidine, procainamide and disopyramide. These are now rarely used but may be considered for certain supraventricular and ventricular arrhythmias, especially when other options are unsuitable. A mnemonic to help remember them is Queen proclaims a dynasty. Class 1B drugs include lidocaine and mexiletine. These are especially useful for treating ventricular arrhythmias, particularly in the setting of ischemia, such as after myocardial infarction. To remember them, you could try late modulators in reference to their action on late sodium current. Class 1C drugs are flecainide and propafenone. These are potent agents used for atrial fibrillation and other supraventricular arrhythmias, but are avoided in patients with structural heart disease due to proarrhythmic risk. You could try saying, "Can I have fries, please?" to help remember them.